Hi, I'm Lindsey Smith, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. In this episode, we're continuing our Next Gen Journey series featuring conversations with learners and early career practitioners in medical professions around the globe. Today we have Dr. Bradley Segal, a physician in the Health Department of South Africa with a self-described passion for technology and innovation. That is evident by his roles at 2 tech companies in South Africa and his master's degree in biomedical engineering, focusing on the applications of machine learning for health. Dr. Segal has worked extensively at the intersection of healthcare and data science to develop solutions to the challenges found in low-resource health systems, often serving as a bridge between technical and clinical teams. Additionally, Dr. Segal participated in a thought leadership event in April with 2 of my colleagues who I work closely with, Greg Keeter and David Game, where you all discuss the future of health science education and teaching. We're looking forward to learning more about all of that and how he thinks the future of medical practice will be shaped by artificial intelligence. Thank you so much for joining us today.
Thanks so much for having me.
I'd like to start with learning more about you and what first got you interested in medicine.
I don't have the most interesting answer. I initially didn't want to do medicine. Initially, I was quite keen on pursuing something like actuarial science. Eventually, I thought that as I learned more about it, it sounded a bit more boring than I expected. I ended up wanting to do engineering, thought about doing biomedical engineering. In South Africa, we go to medical school either directly outside of high school or there's a way of joining it as a postgraduate. So it wasn't even near the top of my suggestions. I ended up shadowing a number of doctors as part of my high school career. I think I got a very skewed view of medicine. I was watching a bunch of interventional cardiologists. I thought that looked very, very cool. I always enjoyed health systems and biological processes, and I thought that it would be a fun thing to study. I always thought it would be interesting to be able to interrogate health problems, be able to see where I could make a difference. And so that's how I got into medicine. I was in, I think, for quite a rude awakening when I realized what I'd signed myself up to, but it wasn't necessarily the first thing I thought of doing.
Thank you so much for sharing that. And what I find interesting there is that medicine wasn't on your radar initially. And I think we'll get to that about how it became on your radar here in a bit. But I know you do have a passion for technology and innovation. Can you talk about kind of what sparked that passion?
So I think the passion was sparked purely initially by me just being a massive nerd. I love technology. I love problem solving puzzles. And so I've spent my entire high school and even during medicine career, spent a lot of time doing programming, a lot of times working on various tech solutions to things. Oftentimes they were more personal. I was playing things with like Sudoku solvers and the like. As I went up into the more clinical spaces, though, I got more involved with health inefficiencies and problems with solution design. And so that's where I sort of sunk my teeth into where systems are a bit inefficient or failing to serve their purposes. And it ended up being a lot more of me trying to see where I can help, where I can improve things. And I think the main thing at the end was that I really enjoyed this idea of like scaled impact, where you could get involved with problem, solve it once for potentially hundreds of thousands of people and have an impact at that level, as opposed to potentially doing it one patient at a time, which was what I was feeling at the time.
I like that your passion came from finding the problem and then ultimately the solution, which has an incredible impact on so many people. I want to kind of switch gears slightly here and talk a little bit about your education journey, which is quite impressive. So you took on earning 2 demanding degrees at the same time, your medical degree and a master's in biomedical engineering. What was it like to do both at the same time, number one? And number two, do you have any advice for our listeners who might be taking on a similar challenge?
Sure. So initially, just for context for Outback, for anyone who's not familiar with how the health system works in South Africa or the United Kingdom, we do a 6-year intercalated medical degree. So it'll be effectively 2 years of preclinical sciences, 2 years of clinical sciences, and then 2 years of practical medicine. It's oftentimes in clinics or in hospitals. And then afterwards, you'll do 2 years of on-the-job training. It's internship, which you rotate through a number of medical subspecialties. After that, you'll have full practice rights for working in general practice. So for myself, I got involved with medicine in first year. I was involved in some projects, not really, I didn't have this idea of trying to pursue anything at that point. Towards the end of my second group of modules, so this is where I'm doing after I finished preclinical, I'm doing my clinical work now. I got involved in a few research projects looking at like epidemiology, drug resistance patterns, and I really enjoyed it. And at that point, I started talking to my university about potentially wanting to do something a bit more formal in the space. It was a bit of an uphill battle because up until that point, no one had ever done it. They wanted me to stop medicine, go study something else, and come back in. So I was lucky in that COVID had just happened. And so what ended up happening is I was registered for my engineering degree by mistake. And they wanted to deregister me because at that point, no one was allowed to do 2 degrees at once. And because of COVID, everyone forgot. So I stayed quiet about it for 2 years. And at that point, it was quite challenging because what I was effectively doing was I was getting to clinics at 7 a.m. in the morning, working the whole day, coming home, working on the engineering and research work, and oftentimes going to bed like 2, 3 a.m. in the morning. And so it's quite demanding time-wise. I think I was helped a bit by the fact that the pandemic was happening. So I think there wasn't as many other pressures on me at the time. But I will say is that it was a massive boost for me medically, surprisingly. I was quite expecting to be hating the medicine work I was doing and be enjoying this new thing that was a bit different. But what I found was that it gave me this diversity of what I was working on and that I could spend my days hitting a medical problem and then work on something very, very different. But the ideas and the work were complementing each other. And so I actually ended up enjoying both more than I thought I would at the beginning because it gave me this diversity. And so, I mean, if I had to give any advice to anyone looking at doing something similar, firstly, don't expect it to be a walk in the park. It was a very grueling 2 years. And if it is something that you're concerned about impacting medical performance, impacting some of the work you do, need to be cautious about the fact that you may be taking too much on at once. So to gear up to make sure that you're at least set up to have that kind of capacity. But the second thing is that if you are looking for something that diversifies the work that you're doing and that gives you broader scope, it is something that is quite enjoyable, in my opinion.
Thank you so much for giving us that advice. And I think, I can see how challenging that could be for you, simultaneously pursuing both of those degrees. And we hear a lot from our medical students who are just in medical school that it's like drinking from a fire hose. So I wonder if what you were doing with these 2 degrees at the same time would be drinking from 2 fire hoses, perhaps at the same time. I'd like to know a little bit more about your work in data science, especially your focus on helping under-resourced health systems. Can you share a little bit more about that?
Sure. I think the under-resourced part of that tends to be the overriding problem, which is that in the where I work, which is in the public sector in South Africa, it's often more a data engineering challenge than it is a data science challenge. You oftentimes are the first person to actually start collecting data or to start setting up these data management systems, because for lots of things, they just run on paper and they've run on paper for forever. And there's never been much of a drive to change that. So quite a lot of what I've worked on in the public sector has either been trying to set up data collection systems or to try and set up ways of automating data collection processes, which was not what I initially signed up for, but it was where the problem was that needed to be solved. Like I mentioned before, I got my start working with epidemiology data, started looking at infectious disease patterns, looking at drug resistance work. It's one of the few forms of data that's well captured on our lab systems here. I then got involved working in surgical discharge analysis. So we started collecting discharge summaries from various hospitals and started looking at what people were operating on. I think the more rewarding part of that was that we were actually able to do it, because before then it was a literal manual exercise. You had to go and physically look through all the discharge summary systems, which were all at that point just archives and archives of files that were put in a room somewhere. But then I think we got a bit more technical. I, at the time, was working also on my master's on generative imaging. So we worked on creating synthetic chest X-rays. So it's similar to what would nowadays be like a diffusion system for making images from text. We were doing that for chest X-rays, looking at trying to make specific examples of particular diseases for education purposes. I also then started working with a few of the startups I work with now, one being Philaxis, who worked on HIV risk estimation. So the goal being to try and identify what was driving HIV risk in the communities, identifying people at risk, and helping to provide decision support for that. So one challenge here is that obviously HIV is a tremendous burden. There's some areas of the country with very high prevalences. The difficulty being is that it's oftentimes a changing phenomena because we are treating it now. And so the patterns that may have been there 10 years ago don't exist anymore because a lot of people are on treatment. And there's actually quite a variety of risk across the country. So some places are driven more by just prevalence. So you just have a high risk of being exposed. Other areas are driven predominantly by behavioral issues where people are generally traveling a lot or they maybe have quite a number of sexual partners. So we set out to try and actually standardize that risk because up to date, the advice is just find high risk people and put them on treatment. And it was proving to be a bit harder than I think people expected it to be. So we ended up building a behavioral risk system, look people's self-reported behaviors over the last 6 months to a year, and predicting which people would pick up or seroconvert for HIV within the next 3 to 6 months. And what we've done with that is try and use that as a tool to identify people that should be on pre-exposure prophylaxis, as well as using it as a distributed tool to look at risk patterns. So you can then look at what is driving the risk in various different geographies. That is something that's currently being rolled out at a few health facilities across the country. Something else that we're looking at, we've partnered with a group from the US that is doing sexual health chatbot work. And so that's going to be the main tool underpinning a lot of HIV counseling work evaluated with things like a chatbot like ChatGPT systems that we'll be seeing in the next few months.
Nice. Yeah. Thank you for kind of outlining the process there, and the HIV risk project seems very interesting. So it sounded like when you were kind of walking through kind of how you operate in these data science projects, you first start with kind of the data collection with, try to incorporate some automation there, then some analysis work happens, and then the action and the kind of the steps moving forward. Is that a correct kind of summarization of the steps that you kind of take along that data science work?
Yes, I mean, what I'd say is that generally speaking, when you get involved with the projects in a bit more set up environments, you arrive, there's 5, 10 years of data already being collected, and your job is to think through the problem that this data could be used to solve. Oftentimes in the low resource setting, the problem is backwards. It's that you see the problem that you want to solve. So you have to put together the data collection pipeline that you can then see if it actually looks realistic and then actually build the solution in place. And so it's oftentimes you're having to work a much more end-to-end process than you would be in more well-equipped environments where you can piggyback off existing tools or existing processes that may exist.
Makes sense. Thank you so much. I want to talk a little bit about your work with WIT's Healthcare Innovation. And it's my understanding that it's focused on helping the overburdened public health systems in South Africa. Can you share a little bit more about that?
Sure. So, I mean, I think the group there was mainly set up as a space for people in the clinical environment to try and collaborate with people willing to donate their time from a technical or computational background to try and find digital health solutions for low resource environments. So what I usually put on the tag. I think the lesson we learned there in over 5 years of involvement is that generally speaking, it is very, very hard to solve something in practice than it is to solve things on paper, which doesn't sound like a great lesson to have learned, but I think that it's a very nuanced lesson. And I think that's what we've worked on tremendously is initially we were looking to the sky. We wanted to build full electronic health record systems in the space. We wanted to see about setting up these very large data collection tools. And it was mainly a lot of experience in where are the bottlenecks that are preventing these things from existing naturally. A lot of understanding of where is bureaucracy holding up the process? What are the financial or the process challenges that prevent these things from being solved? So I think that that's an overarching summary. In terms of work we've actually done, I think we've worked on an eclectic bunch of projects. The one I'm more quite happy with is we worked on a bunch of 3D printing solutions for some of these hospital tools. So The biggest one was working with neonatal incubators and trying to make attachments for drip stands or for monitoring equipment, because effectively what was happening was they would buy uh, the incubator, and the the cost would be fixed that they would purchase that, but any of the attachments would be sold separately. And there was just no budget in any of the health facilities who worked in to get that. And so you would walk into a neonatal ICU and there would be bags of fluids hung like over corridors, or like over, there would be a hook on the side of the wall that they would just hook over, or be sticking things all over the incubator. So it was an utter mess. So that was quite a fun project. We spent a lot of time designing and fiddling with trying to make as cheap as possible, but as robust as possible hooks and attachment points. We also worked on a few discharge summary collection systems, trying to collect and organize patient data, because of the paper-based problem. If a patient leaves the hospital and they lose their file, they lose the paper that they were given at the end. Sometimes you would never know whatever operation they would had, or anything about them ever again. I think the last one is looking into trying to do large scale patient vital capture. So we were working on projects to look at like having these standing machines where you would go and put your arm in, get a blood pressure reading, or do a whole bunch of vital measurements in one place, and trying to use that to monitor chronic patients remotely. That unfortunately didn't go very far just due to challenges we had in scaling the project, but it was interesting to work on and see how something you could potentially try and change the way that chronic disease management would be done.
All three of those that you mentioned, the 3D printing, hospital tools, the discharge summary systems, and the large scale vital measurement systems to monitor patients remotely. I mean, they all sound incredibly interesting. So thank you for sharing all of those with us. I noted that you're often a bridge between technical and clinical teams. Can you talk about your approach to that role and what seems to work best as you kind of put on your technical hat and also your clinical hat?
Sure. I mean, I think my approach generally there is to try and be a mediator, because the biggest issue oftentimes is, especially with the larger projects, is that you'll oftentimes have incredibly focused domain experts from healthcare working on one particular problem, and you will have similarly spec'd people from a technical side also working on that problem. And I tend to find from the healthcare side of things, there's a lot of assumption of basic knowledge that people will have about the healthcare space or the specific disease that you're working on, and the overlap can be very, very minimal. I think the challenge is oftentimes you have to have not a complete understanding of both sides, which is, I think, a bit of a misconception, because I think a lot of people feel uncomfortable if they don't understand everything about the healthcare and everything about the software development side of things. I think you have to be comfortable to the point where you can understand the clinical point that you're working on, the process, what the disease is. And the reason you still have domain experts there is because any nuances that you don't understand, that is their responsibility to fill in. On the technical side of things, same story. You don't necessarily have to be the one building every part of the technical solution, but you need to understand what are the limits of that tool, what are the challenges or the hurdles that you're going to face when trying to build the solution, so that you can temper expectations. And so what I would say is that as an approach, it's about being aligned on terms of what the problem is, aligning the language and aligning the solution. So from a problem perspective, it's making sure that everyone actually is aware and understands what you're working on. Oftentimes that is a bit of an ask from both sides, because from the healthcare side, some of the teams oftentimes think it's obvious. They see this every day. Well, it's something they're always grappling with. So it's simple. People from the technical side oftentimes are very out of their depth. It tends to be vice versa on the solution side, where people thinking about how this can work in a healthcare space from the healthcare worker's perspective often think that the solution is much more simple, easy to put together than it may actually be. And the time that it may take to develop something or put something together robustly can be a bit of a surprise. And then oftentimes you have these two groups that are speaking completely different languages. So it's oftentimes being a translation layer. As an example of what this may look like, for a recent project we were working on looking at silicosis and TB screening in mine workers, one of the technical teams asked what similar diseases they could look at for looking at disease labels to try and identify additional data sources. And the one healthcare team sent back a like 1 to 2 page document with medical differentials back to them. So I got an email saying that they understood maybe 5 words of the actual content of that email. And so it was an exchange that took 2 to 3 weeks and wasted everyone's time. And ostensibly just trying to make this system better, but no one got anywhere just because there was no way of actually mediating the difference between the two.
Yeah, absolutely. And it sounds like your role as a mediator slash translator slash expert in all the things really kind of helps bring everyone together to understand the challenge and then, work together to, create that solution. So I think you have a really critical role in all of that. Where do you think you will focus your career long term, given your knowledge of medicine, AI, and biomedical engineering?
So it's a bit of an open question. I think I can give you the broad view is that I've recently received a Rhodes Scholarship and I'm planning to go to the UK for 2 3 years to do a PhD in clinical AI applications. And so I'm thinking my current goal is to try and move more firmly into working in the intersectional point between health and technology as my mainstay of work. I'm still practicing clinically, and I think it's taken a lot of time and effort to convince myself that this is something that is a viable career move. I think that for a lot of people that I work with, there's this perpetual feeling that if you are not fully staying within the clinical pathway, getting towards the end of various specialization paths, you feel that you don't feel like you've necessarily done what was necessary for your medical degree. You feel like you may have wasted a lot of time. And I think that I've finally reached the point where I feel comfortable that I've done the clinical thing. I've enjoyed it. I've had quite a lot of experience. But where I see this massive opportunity to work is moving on these projects at this intersectional point. And that's this move for me to do a bit of academic time and then move into that space more permanently is my way of completing that transition.
Well, first of all, congratulations. I'm sure you'll do great things when you start that program. I know at Elsevier we've recently launched Clinical Key AI and really interested in all of the great work that is happening in the AI space. So really enjoyed learning a little bit more about how you're thinking about that. What are some of the most important ways you think medical practice will be shaped by AI in the coming years? And what do you think this means for both providers and patients?
Sure. I mean, I think I'll speak more to how I think it will have impact within the low resource setting, because I think as much as a lot of AI development or machine learning development is being done in the developed world, quite a lot of the benefit actually doesn't sit there. Because if you think just on a radiology standpoint, in some areas of South Africa, which is, if you're thinking in terms of Africa or the developing world, it's one of the upper level developed countries in that space. There's areas where there's a 1 to 1 million specialists to patient ratio. So for ophthalmology, for various forms of radiology, the ratio of patient to provider is extreme. And so where a lot of AI development and implementation is being done is in places where there is a lot more medical presence in the space, where is a lot of the benefits is actually probably going to be in spaces like that, where there is absolutely no one that is seeing these patients being able to do the tasks that are needed. And so being able to scale that doctor's impact across that group of people transforms the way that medicine would be practiced. And so I think that with the rise of diagnostic support tools, enhanced triage tools, or decisions, or more like automated diagnostic tools, although jury's out on whether we'll see those being implemented without oversight, I think that those are going to have a tremendous difference in these environments over the next 5 to 10 years, because it means that more people are going to be able to access diagnosis or being able to have an image, an x-ray done and be flagged as potentially having a particular condition. And you can weed out a lot of people that don't necessarily need to be seen. And so I think that it will enable greater health coverage without necessarily having to massively expand the pool of doctors where there may not necessarily even be people to expand into. I think from a patient perspective, I'm very excited about these medical chatbots and these counseling tools. I I know there's still a bit of controversy about how effective some of these tools will be, but I do think that there is definitely space for tools that are going to better able to explain or counsel patients on their conditions, offer health education, predominantly in their own language and their own level of understanding, which I think oftentimes we as clinicians are a bit challenged in terms of providing. And in particular, in a low resource environment, oftentimes, speaking about South Africa in particular, language barriers are also a tremendous thing. Generally speaking, in my clinical day, I will see at least one patient that speaks one of four different languages, oftentimes English not being one of them. And so there's a massive challenge in terms of offering health education, because while it may be easier to say that they're hypertensive, offering any degree of counseling to them about what they can be done to better manage their condition becomes very challenging. And so I think being able to have those support tools will massively improve patients' ability to engage in their healthcare and be able to understand their own conditions, potentially in ways that we haven't seen before. Having the ability to have a chatbot at home explains to you your condition, but also is quietly screening you for complications or checking that your symptoms are actually improving and flagging that for your doctor to see the next time they see you.
Yeah, absolutely. As you were talking, it kind of reminded me of some of the work that we've done at Osmosis. And, we take these really complex medical, topics and we break them down to really bite-sized, digestible, engaging, fun videos. And we've done some work in the rare disease space as well. And, obviously our audience is future medical professionals. So we know we'll get that audience. But we've also been able to kind of reach into that patient market with putting our You're the Zebra videos on YouTube. And so we've seen comments like, I've never been able to explain my condition, up until this point. And so I think it just kind of reminded me as you were talking about that, about, giving patients, that coverage and being able to kind of inform and teach them about the conditions that they are having. So thank you for sharing that. I want to move on to kind of talk a little bit more about the clinicians of the future, and wanted to ask you what you think the key skills of a successful clinician will be in the next 5 years.
I don't want to end up repeating what I think a lot of people have said in the space. I think there's a lot of people that say that AI is not going to replace clinicians, clinicians with AI, clinicians with these various decision support tools will replace those that don't use them. I think that is broadly true about medical practice. I think everyone is going to be exposed to more and more tools than they've had in the past. I think the main skill set that's going to become increasingly relevant is the ability to not necessarily understand the technical components of these systems, but to understand how they are evaluated and where their limitations are. Because what is starting to happen more and more is these tools are becoming much more mainstream than they were 5 to 10 years ago, not necessarily because they're always better, but because they are much more popular. And I think the challenge is being able as a clinician to decide that the tool that you're using has clinical merit as opposed to it just looking good. And I think that comes down to two things. The one is being able to interrogate or understand how these tools will be tested and implemented, which, to be 100% honest, is mainly an expansion of someone's ability to evaluate research, because the way that it's going to be tested and evaluated is very similar. There's, I think, a bit of a jargon and a bit of an understanding in terms of how the actual technical side will be tested, but that doesn't need you to understand all of the mathematics or all of the software that underpins it. I think that that's going to become an increasingly important skill, because it will enable you to sift out and weed out where these problems actually sit. And I think the other thing is an understanding of when not to apply these tools, because what is a big challenge is a lot of the time, because you can apply a digital tool to something doesn't necessarily make it better. One example, without divulging names of companies involved, there's a trial that's looking at chest X-ray screening for tuberculosis in South Africa in the primary clinics. And the tool is wonderful. It has excellent performance metrics. The system is done in a mobile X-ray van. It works very well. The challenge with it is that the actual implementation of it hasn't been thought through in terms of what someone in a low resource environment who gets the report is going to think. Because you get a report that says that someone's got a 0.94% risk of this. No one knows what to do with that. I mean, a lot of people, they're not expected to, especially if they're working in environments where there's no person with extended clinical training. They may not necessarily know how that must be interpreted, what to put them on. Aside from this tool, I found in the clinic I was doing some support work at, there had already been 2 or 3 patients just in the few days that I'd been there who had been diagnosed with and started on TB treatment on the basis of a AI report that the various TB focal point clinicians were misinterpreting, because it was picking up old TB. It wasn't clearly differentiated on the tool. And because no one had thought through this part of the implementation process or thought through this particular problem, that is something that is being implemented quite a bit more broadly. So I think understanding where these systems can go wrong and understanding how not to use them at times is oftentimes more important than when to use them.
Exactly. And so what I heard there is just really understanding how to evaluate the research, interrogate it, and also understanding when not to use those tools. And there's a time and a place, I think, for all of these tools. So at Osmosis, we are a teaching company and we love to fill knowledge gaps. Is there a topic you think Osmosis should make a video about to fill a gap that is particular concern or of interest to you?
I think the one I just outlined, probably.
Okay.
I think there's definitely a need for good educational materials, just making it simple to understand how these tools are evaluated and how someone may go about understanding what the research actually means. Because it's not completely different from understanding a normal research paper. It's just a little different because some of the work is being done on a computer and some of the evaluation metrics aren't entirely familiar to someone who's working more with clinical research.
Awesome. Thank you so much. We'll see if we can get that into the pipeline at any time soon. So my final question for you today is that we have many students and early career health professionals in our audience listening in right now. What advice do you have for them about meeting the challenges of this moment and approaching their career in healthcare?
Speaking to what my experience has been, I would say that you have to be open to a change in directions. I think that is the prevailing theme from what my experience has been, which is that everything I planned on doing ended up changing multiple times before I actually ended up sticking to what I wanted or what I thought was a good opportunity. And every time I planned anything in advance, I proved to have completely missed the mark on what actually was going to end up happening. And I still think that despite that being the case, I've ended up in a much better place than I initially envisioned I would end up working. I think in terms of actually looking at problems to address or looking at spaces, if you want to involve yourself, I think the most important lesson I can give is to question why problems exist, not what problems exist. Because what oftentimes happens is you will see a problem, you will see a bottleneck, you will see a care gap, you will see something that is happening. And your immediate thought is, here is how we solve that. This is the change you implement. This is the new tool you put together. This is the thing you install. What oftentimes happens is you will do that a few times until you find out that that actually may not have been the actual problem. The actual problem may have been something sitting 2 or 3 steps behind there, and you're seeing the symptom, not the actual cause. And so most importantly is to think through what are the causes of the things that you're interacting with. And that will give you greater insight into, firstly, why the systems are what they are. And secondly, find more interesting places that you can get involved. And I think more impactful places that you can be involved. And I think that by looking at solutions from more so a systems perspective, you get a better perspective on where your effort is most well spent. And it gives you opportunities to do things that no one else is thinking about. Because I think a lot of people, and this is predominantly true in the machine learning space, will attack problems that are obvious to see where a solution can be implemented. It's oftentimes a lot more thought necessary to think about where that solution should be implemented.
So just to recap, those tips for our audience: question why the problem exists, to understand where the effort should be spent and where the opportunity may be. Be open to change in direction. And in cases like Dr. Segal's, it usually does work out. That's all we've got for you today. Thank you so much for being with us today, Dr. Segal. This has been a wonderful interview.
Awesome. Thank you guys so much.
I'm Lindsey Smith. Thanks for checking out today's show. Remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.